Okay, welcome back. And this is the second portion of the gastroenterology part of the internal medicine review course. I am Dr. Romano, and we continue with the malignancies of the GI lumen. And we begin with the esophageal cancers. Right. Esophageal cancer is mostly located at the lower third of the esophagus. You see here, it accounts for more than half of all the esophageal cancers. And depending on where you are in the world, your histologic type will vary. It is more common in the West to have adenocarcinomas, while here in the eastern part of the world, it is still predominantly squamous cell type of cancer. Previously, the predominant type of esophageal cancer worldwide is squamous cell carcinoma, but because of the increasing prevalence of GERD, which is a risk factor for the formation of Barrett's, and at the extreme end of the spectrum are adenocarcinomas. So these adenocarcinomas are mostly related to the presence of GERD for a protracted period of time. All right, the symptoms, of course, is progressive dysphagia, and the dysphagia will begin when the esophageal obstruction is about 60% of the esophageal lumen, or if the lumen is less than 1.3 centimeters in diameter. Weight loss of short duration is also found in majority of patients with esophageal cancer. These are the risk factors for the development of esophageal factor. On the left side, you're going to see factors that are associated with the development of squamous cell cancer, while on the right table, you're going to see factors that are associated with the development of adenocarcinoma of this esophagus. What is common to both types of esophageal malignancy is cigarette smoking. So cigarette smoking is a risk factor for both squamous cell cancer and the esophageal cancer of adenocarcinoma type. If you're going to look at all of these factors, as well as these factors, you're going to notice that squamous cell carcinoma is related to prolonged exposure to substances, while adenocarcinoma is associated with prolonged reflux disease. Now, one more thing to emphasize here, that chronic achalasia is a risk factor for the development of SCCA, because chronic achalasia is also a predisposing factor to chronic exposure to substances in the esophagus, and this is a long-term complication of stasis esophagitis, and it predisposes to the formation of squamous cell cancer of the esophagus. All right, so how do we diagnose esophageal cancer? Of course, we can do an esophagogram, but of course, the better test would be an endoscopic examination, because you're going to directly visualize the tumor, and of course, it's going to offer you the opportunity to take biopsies. CT scan and PET scan and EUS are done for staging, not necessarily the diagnosis. The treatment for esophageal cancer, if you're going to look at your book, will be surgery, chemotherapy, and palliative treatment for esophageal cancer. And this prognosis seems to be very poor, but more recently, because of the cross trial, we are now promoting the use of concurrent chemoradiation therapy, which is neoadjuvant, meaning there is an intent to do surgery. And this, of course, will warrant that the patient is a surgical candidate to begin with. And this has changed the way we treat esophageal cancer, because you give this to both adenocarcinoma and to squamous cell carcinoma, because we know that there's limited response of adenocarcinoma to radiation. They are relatively radiosensitive, but there has been proven benefit of the use of neoadjuvant chemoradiation for both adenocarcinoma and squamous cell carcinoma of the esophagus, and we have seen better survival rates over the last few years. In fact, it can be as high as 45% if it is localized. Adenocarcinoma, as I've said, also benefits from chemoradiation therapy. Gastric cancer is different. Adenocarcinoma is a predominant histologic type. It occurs at about 85% of all cases. Lymphomas is an important differential diagnosis, especially for diffuse type malignancies, and GIST and leiomyosarcomas, while less common, is also one of the tumors that we see in the clinics. And this is, of course, a very good differential diagnosis for localized or seemingly local tumor in the stomach. Diffuse type and intestinal type, this refers to the involvement of the stomach in the malignant condition. Diffuse type is usually more commonly seen in younger patients, but of course they are more aggressive and hence you have poorer prognosis. Diffuse type is what we usually refer to as linitis plastica, wherein there is a generalized involvement of all the layers of the stomach, and this is what we call the leather bottle appearance of the stomach. Endoscopically, when you see linitis plastica, this will be characterized by poor distension of the gastric folds, even on maximal air insufflation. Okay, intestinal type, these are the more localized type in the sense that it does not involve the entire stomach most of the time. They are the typical ulcerating lesions, and they are typically found in the antrum and the lesser curve. We said earlier during the discussion of peptic ulcer disease, these ulcers tend to be irregularly looking. They usually are solitary, and they do not respond to PPI therapy. So it is a long precancerous process which usually involves the infection of H. pylori, which is again considered a class 1 carcinogen. That's why it's imperative that if you document an active infection of H. pylori, that you give the proper eradication regimen as we discussed earlier. Symptoms of gastric cancer is varied depending on the location of the tumor and the stage of the tumor. It ranges from being completely asymptomatic to obstructing in nature. So if your tumor is in the pyloric area, then you expect obstructing lesions, specifically a gastric outlet obstruction, where the typical PE finding would be a positive succussion splash. Dysphagia, of course, happens when the tumor is in the more proximal part, which may involve the cardiac portion of the stomach or even the GE junction part. The diagnosis is, well, traditionally X-rays, but of course endoscopic procedures are preferred whenever possible to see the tumor directly and to take biopsies. CT and PET scan are helpful in also the staging, as well as EUS. EUS is one of the best tests for local regional staging of the upper GI tract. Treatment, of course, is surgery whenever it is the patients are found to be a good surgical candidates, followed by chemotherapy. And for GISTs, which you have to document the positivity for c-KIT or CD117, you may use tyrosine kinase inhibitors such as imatinib, or for imatinib-resistant patients, sunitinib. Radiotherapy, you may offer this, especially if this is palliative or if the patient is bleeding from a tumor. But since majority of gastric cancer is adenocarcinoma, we know that they are relatively radio-resistant. So we cannot offer radiotherapy alone if our intent is to cure. So next question, which of these polyps is a risk factor for colonic cancer? Is it hematomatous polyps, hyperplastic polyps, inflammatory polyps, or is it adenomatous polyps? Colon cancer is one of the most common malignancies worldwide, and here in the Philippines, you're going to see that it's the fourth most common cause of malignancy, and also here, if you look, it's the fifth leading cause of cancer-related mortality in the country. This is from Globocan 2018. So they usually arise from adenomatous polyps, and these polyps actually begin to be more common as we age. So you see it in 30% of middle-aged patients and about 50% of elderly people. So for elderly in this definition is 65 and older. Now, while this becomes more common as we age, the number of polyps that actually become cancerous after some time is only less than 1%. And usually, if it will become malignant, it takes about 5 to 10 years before it becomes clinically significant. Now, there are other pathologic types of polyps, such as juvenile polyps. These are usually hamartomatous in histologic nature, and they are non-neoplastic. Hyperplastic polyps are just benign mucosal proliferation, but you have to be careful because histologically it may resemble the sessile serrated adenomatous polyps, which are more aggressive than the traditional adenomatous polyps. Then again, adenoma, this is what we will discuss in some more detail in the next few slides. The following are the risk factors for colorectal cancer. So if you see here, animal fat is a risk factor. Being male is slightly at a disadvantage here for the development of CRC. Obesity has been established as a positive risk factor for CRC. Insulin resistance, so if you're going to add that, metabolic syndrome is a risk factor for CRC. Smoking is also an established risk. Now, these on the right with the red font are actually risk factors, personal risk factors that increases the tendency of the individual to develop colon cancer. So if you have family history, if you have in your family hereditary polyposis syndromes, if you have a personal history of IBD such as UC or Crohn's, and the magic number here is 8 years. So if you have an active IBD 8 years or longer, you need to be screened for malignancy. And if you had a previous endoscopic examination and you were found to have neoplastic polyps or adenomatous polyps, then actually it raises your risk of development of colon cancer. Now, the adenoma carcinoma sequence is the most studied pathway of the development of cancer. So it starts from having a normal colonic mucosa, and then through a series of mutations, especially in patients who have syndromes, there is a sequence of genetic abnormalities which will trigger a cascade of changes which will result in adenoma formation and then ultimately a carcinoma. And this adenoma to carcinoma transition takes about 5 to 10 years of time. That's why when we do our screening for colorectal malignancy using endoscopic procedures, if we have not seen any adenomatous lesions, or if we have removed adenomatous polyps, in some cases, we say that we need to follow up after 5 to 10 years because it takes about that amount of time before a new one develops and becomes clinically significant. So it also depends on the appearance, or there are polyp-related factors that determines its risk to develop or its potential to be malignant in the future. So the first one is its appearance. Is it pedunculated, such as this polyp here? So you see a stalk, or is it flat? like this, or what we call sessile polyps. Is it after taking biopsies? Is it mostly composed of tubules, or is it mostly composed of villi? So the distribution of these structures inside the polyp will determine its histologic type, and of course, those villus types carry the higher risk to the progression to malignancy. And lastly, the size of the polyp is what matters. Now, the significant risk is for large polyps, meaning if the size is more than 2.5 centimeters. So when I was preparing this a while back, I remembered a possible mnemonic. So this is from Killing Eve. So here, this is villanelle. So I thought that it's a villus type. If it's flat because you're carrying a blade of more than 2.5 cm, then those are the polyp-related risks to develop malignancy later on. So here are the guidelines for screening of average risks individuals, and we are going to define what average risk is in a while. And these are the recommended screening tools, and depending on the screening tool is the recommended interval between between the previous and the subsequent test, depending on the test. Here in the Philippines, we actually have published guidelines for the management and the diagnosis of colorectal cancer. And here in the local guidelines, these are the tests that we recommend that we do. So in FOBT, but more specifically FIT, or fecal immunochemical test. This is a more sensitive and more specific test compared to the traditional guaiac-based tests, stool tests, flexible sigmoidoscopy, and colonoscopy. Of course, of these three, colonoscopy is considered the best because it's going to allow you to see the entire colon, and it's going to allow you to remove polyps, or if there is already a tumor, you can have also a biopsy sample of the said tumor. Now, of course, while colonoscopy is the best, it doesn't mean that it's the only valid test. In fact, the Philippine guidelines recommend the use of at least the FIT, and if they have a positive FIT test, then these are automatically an indication to get a colonoscopy, a complete colonoscopy. So again, those recommendations are for average risk individuals. So the average risks are these patients, but for you to understand what average is, you need to understand what the increase and high risk population are first. Now, the red ones that the red items earlier, these are factors that increase the risk of the individual of developing CRC, and those with polyposis syndromes and the personal IBD history of 8 years or longer, these places a higher risk for that individual. Now, if your patient does not have all of these increased risk factors and high risk factors, then they become average risk individuals if they are over or at least 50 years of age. Now, a few years back, there's a debate on whether there's a need to decrease the the age of screening to 45 or 40. But here in Asia, it's still 50. Okay, so if there are increased risk individuals, we usually start them at 40, or if they have a positive family history, you need to deduct 10 years from the index, the age of the index of the relative who had cancer. Now, this is presupposing that this becomes less than 50 or 40 and younger, because if the family history is a relative who had cancer diagnosed at 65, then that doesn't apply anymore, because we also have to understand that the role of family history only becomes more significant if the age of diagnosis is lower, meaning as we age, the factor of family history becomes less important. Okay, the diagnosis traditionally, but of course, you can still use barium contrast study even if it's not as sensitive. Colonoscopy, as we said, is the gold standard. EUS or pelvic MRI becomes very important not in the diagnosis, but in the staging of colorectal cancer, because rectal cancer is managed and treated differently compared to cancer in the other parts of the colon. CT scan of the abdomen is a minimum. Before, we say that we only do a chest or recommend a chest CT if you have a patient with rectal cancer, and we're going to discuss why in a while. But right now, the current NCCN guidelines recommend a chest CT and an abdominal CT. Both, of course, are contrast studies for any malignancy in the colon, whether it's rectal or non-rectal. PET scan is for distant metastases, and I would like to emphasize the use of CEA. CEA for colorectal cancer should not be used for the diagnosis, but rather as a prognosticator. Okay, so a high CEA preoperatively or pre-treatment is a poor prognosticating sign. And if you monitor your CEA, which should dramatically decrease in value after surgery, if there is a resurgence of the CEA or if there is an increasing trend post-treatment, then it may predict tumor recurrence. Now, this is the reason why previously we said that in rectal malignancy, you have to get a chest CT because, well, it depends also on where in the rectum your tumor is. Now, because if you have an upper rectum or a middle rectum, you see here that the drainage of their venous system is different compared to when you are in the lower part of the rectum. You see here that this portion is being drained by the inferior mesenteric vein, and you know that the inferior mesenteric vein will ultimately drain into the portal vein, and then it will end up going to the liver. And that's why if you have an upper rectal malignancy, you expect that the metastasis goes to the liver, while for these lower part of the rectum, they drain actually into the internal iliac vein, and they go directly to the inferior vena cava, bypassing the portal circulation, and therefore you may have lung metastases even in the absence of liver metastases. And that's why it becomes important for staging that you also get a chest CT scan. But again, as I said, in the current NCCN guidelines, it doesn't matter anymore whether your patient has rectal or a higher tumor. They are now recommending the use of contrast chest CT scan. But for our setting, probably we can still adhere to the previous guideline. This is how we stage colon cancer. Obviously, the T staging depends on the depth of penetration, not actually the size of the tumor, but on the layer of the bowel that it penetrates. So if it already penetrates through the muscularis propria, which is here, then automatically it becomes T3. If there is positive node, then becomes already stage 3. So these are very helpful markers. And of course, the earlier the stage, the higher, the better the 5-year survival. Now, this is classic in the sense that there has been very little change over the years, but what is not shown here in this diagram from Harrison's is the presence of the stage 0, or what we call as carcinoma in situ, wherein the tumor is localized and only involves the mucosa. And the treatment for this actually is just endoscopic. You can just dissect the tumor endoscopically, and this already is curative of the disease. But unfortunately, we see very, very few of these stage 0 colon cancers. Okay, so treatment is, of course, surgery for most of these cases. FOLFOX or CAPOX or FOLFIRI is still the standard treatment for colorectal cancer. For radiation therapy, you only recommend that if your patient has rectal malignancy, if they are node positive by EUS or MRI, or if there is an extension beyond the muscularis propria, because they will benefit from radiation therapy in the sense that it will increase the progression-free survival and the local recurrence, and they also can potentially downstage the lesion preoperatively to ensure better local control. Endoscopic therapy again is for stage 0 disease or carcinoma in situ, and now we are seeing more and more immunotherapy or immune targeted therapy depending on the genetic mutation that you see in your patient. So you can give these monoclonal antibodies, bevacizumab, cetuximab, panitumumab. These are the more commonly given monoclonal antibodies depending on the KRAS or BRAF mutations. These are the more recently included treatment modalities, nivolumab and ipilimumab. Again, if you satisfy the genetic profile of for which these treatment modalities are given. So obviously, the answer to this question is a tubular adenoma. So with that slide, we conclude the luminal portion of the roadmap of the GI review for the medical board review course. So we now continue with the rest of the GI organs, and we start with the pancreaticobiliary tract. So these will be the topics that we'll be discussing in the next few minutes. And we start with gallstones. Now, when we say gallstones, they are the precipitation of cholesterol and concentration inside the gallbladder. So basically what most of these pathophysiologic events that lead to gallstone tells us is that there is an increase in the concentration of cholesterol that is being secreted into the gallbladder, right? So when we say gallstones, meaning stones that are present inside the gallbladder, we are talking about most likely cholesterol type stones, and which is what is more than 80% of all gallstones are made of. Now, for these cholesterol stones, they are mostly, obviously, cholesterol monohydrate crystals with some calcium and bile pigments included in the stone. While for pigment stones, which is the second type, it's less than 20% because these pigment stones are more commonly seen in primary bile duct stones. No? So primary gallstones are cholesterol, while primary bile duct are pigment stones. And these pigment stones are mostly composed of calcium bilirubinate. Of course, there is a hybrid between the two, which is what we call mixed stones. Okay, so the pigment stones are further divided into black pigment stones or brown pigment stones. Black pigment stones are because of the hemolytic diseases, while brown pigment stones are associated with biliary infection, such as the presence of Clonorchis sinensis. Okay, so we have I have mentioned this earlier. The pathogenesis of cholesterol gallstones is actually, you have to think of what mechanisms there has to be in place to increase the cholesterol inside the gallbladder. So there is cholesterol supersaturation, which will overcome the milieu inside the gallbladder, which is mostly from lecithin. So if there is the nucleation because of increased cholesterol saturation, there will be a nucleation and there will be crystal formation. Gallbladder hypomotility is a very important factor in the development of gallstones, and this is going to explain a lot of conditions wherein if you have gallbladder hypomotility, you are predisposed to have gallstones, such as when you are in prolonged fasting, wherein you don't use your gallbladder because there is no CCK release. So you will have gallbladder hypomotility and you may develop gallstones. Patients on prolonged parenteral nutrition, again because you are not using your gallbladder because you're not eating. Pregnancy also induces gallbladder hypomotility, so those are risk factors for the development of cholesterol gallstones. Now these is the mechanism again in the development of cholesterol gallstones. You have to only remember that here, if there is an increase in the activity of the HMG-CoA reductase, which is the rate-limiting enzyme of cholesterol synthesis, then you are going to increase also cholesterol secretion into the gallbladder. Now, also, if you are going to remember for the exam genetic abnormality that may predispose to cholesterol supersaturation, you only need to remember MDR3 mutation, and mutation of which decreases the lecithin, which makes the cholesterol soluble, so less lecithin, increased cholesterol concentration, which will trigger crystal formation. So we have discussed this earlier, why some of these are risk factors, but I want to emphasize on this: weight loss, not just massive, but rapid weight loss is a risk factor for the development of gallstones. That's why for patients who are undergoing weight loss surgery or bariatric surgery, they can be given prophylaxis in the form of UDCA so that they will not develop cholesterol gallstones. Pigment stones, again, are mostly composed of calcium bilirubinate. And for black pigment stones, this is related to hemolysis. So if you have hemolytic disorders, if you are cirrhotic, or if you have ileal diseases or conditions of the intestine that affect the ileum, then you are going to have black pigment stones. Now, again, for brown pigment stones, this is related to chronic biliary infection. So this is one of the most common primary bile duct stones that we see here in the Asia Pacific region because of the endemicity of Clonorchis sinensis, and also because infection in the bile duct is really common here in Asia compared to the western part of the world. So how do we diagnose gallstones? The most easily accessible and a very good test for gallstone diagnosis is an ultrasound test. As long as the gallstones are inside the gallbladder, the ultrasound, transabdominal ultrasound, has more than 95% diagnostic accuracy, and you're going to diagnose gallstones if you fulfill the WES sign, which is an acronym for the gallbladder wall, if there's an echogenic focus, or if there is a posterior acoustic shadowing. So for the wall should be hyperechoic. So you see here in this picture that you can clearly delineate where the gallbladder wall is. You see here the hyperechoic focus inside the gallbladder, and of course during the examination the radiographer or the radio technician is going to ask the patient to move. So these hyperechoic structures should also move, and move with gravity. And of course, the last criteria is that there should be a posterior acoustic shadowing. So if you have all of these three, then you can diagnose the patient as having gallstones. Absence of one or more of this should make you doubt the diagnosis of gallstone disease. Now, for some cases where there is an increased concentration of calcium in the stone, you may use a plain abdominal film wherein the calcified stones will be visible. And then HIDA scan. HIDA scan is a test to diagnose cholecystitis because the HIDA should concentrate into the gallbladder, meaning it will come from the liver and then secreted into the bile ducts and then go down and pass through the cystic duct and accumulate in the gallbladder. So if you have a positive HIDA scan, meaning you have accumulated HIDA tracer inside the gallbladder, and then you know that there is no acute cholecystitis, because in acute cholecystitis, the cystic duct is obstructed because of the edema, and therefore the gallbladder will not light up. Okay, 60 to 80% of all patients with gallstones will remain asymptomatic. Okay, and there is a cumulative risk of developing symptoms over time. So age is actually a risk factor for the development of symptomatic gallstone disease. Now, you have to also understand that the risk not only of death but other problems related to gallstone disease is only as little as 1 to 2% per year. Therefore, prophylactic treatment and more, of course, prophylactic surgery is not warranted for all of these asymptomatic gallstone disease. Symptoms of gallstone most of the time starts with biliary colic. In fact, what we say about biliary colic is that it's a harbinger of other complications of gallstone disease, because most of the time, in almost 90% of the time, patients with gallstones who develop symptoms will start with pain. Okay, and then usually this recurrent pain is a sign that there might be some other complications of gallstone disease in the future. All right, so biliary colic is very important that we need to elicit it in the history. It is the most specific and characteristic symptom of gallstone disease. Biliary colic, again, is a misnomer because it is not colicky, but it may have been called as such because the pain is severe, but it's not colicky in the sense that it's steady. When we say colic in GI, it should be crescendo, decrescendo pattern, or waxing and waning. There is no such pattern here. The pain is steady and it should be present for at least 30 minutes, and it can last up to 6 hours, which can subside gradually or even instantaneously, even without any treatment. This actually also more or less happens at night. They are frequently nocturnal, and also the characteristic pain is triggered by a large meal. Now, it doesn't necessarily have to be fatty, but we know that because CCK is mostly and most strongly affected by a fatty meal, so it can potentially be more severe if your patient ate a fatty meal. But again, it does not have to be a fatty meal to trigger biliary colic. So postprandial abdominal pain that is severe, steady, lasting for 30 minutes at least should give you the diagnosis of biliary colic, or at least you know that this is the biliary colic type of pain, and you should strongly suspect a gallstone disease. What is the treatment for symptomatic gallstones? Again, symptomatic only is the ones that we treat. So Lapcole is the gold standard currently. So if your patient has frequent gallstones, or if there are other complications such as cholecystitis or pancreatitis, or if your patient, even if asymptomatic, the gallstone is large, and by large we say that it is more than 3 centimeters, because this is actually a risk factor for the development of cancer in the future, gallbladder cancer. Now, there are other indications, transplant patients or those with porcelain gallbladder. If your patients have hemolytic disorders and who are undergoing surgery for something else, like for example, appendicitis, so you can have a prophylactic cholecystectomy in the same setting. And then patients with undergoing bypass or weight loss surgery, you can also prophylactically remove the gallbladder to prevent what we said earlier, the formation of gallstones. Now, medical dissolution therapy is quote unquote an option for symptomatic patients, but those who refuse, or if they are poor surgical candidates. So when we are asked what is a treatment for symptomatic gallstone disease, the answer is, of course, surgery. But if the patient is not eligible for surgery, or if they really strongly oppose surgery, then you may offer medical dissolution using ursodeoxycholic acid for 6 to 12 months, only if they meet the criteria. Now, they have to be radiolucent stones on X-ray. Of course, you need to get X-rays or even CT scan. There is an actual value that you should get, below which you may say that this patient have radiolucent stones, meaning their cholesterol mainly. If the stone is very small, less than 5 millimeters, and if you have documented a functional gallbladder using the HIDA scan. So if you haven't met this, then most likely, even if you give medical dissolution therapy for your patients, it's most likely not going to work. Okay, so this is the next question. Which of the following is not included in the Charcot's triad? Is it biliary pain, fever and chills, hypotension, or jaundice? So we proceed with the other complications of gallstone disease. First is acute cholecystitis. Cholecystitis, of course, is inflammation of the gallbladder because of the cystic duct obstruction. Now, the pathogenetic mechanisms involved here are inflammation because of increased pressure inside the gallbladder, and then if there is chemical inflammation because of the release of lysolecithin because of phospholipase in the bile, and this is the most common mechanism if there is a bacterial infection causing the inflammation inside the gallbladder, and these are the microorganisms responsible for most of the cases of cholecystitis: E. coli, Klebsiella, Streptococcus, and Clostridium. What are the symptoms and the signs of acute cholecystitis? It is actually progressive biliary colic or biliary type of pain. It need not be right upper quadrant initially. Most of the time, it will start as epigastric pain, but it's going to localize later on into the right upper quadrant. Then this pain typically radiates the intrascapular area or into the right subscapular area or the shoulder, which is known as the Kerr sign. Now, peritoneal signs will only be positive in as the condition progresses. There will be an increased pain with jarring of the abdomen or on deep respiration, like when you are trying to elicit the Murphy sign. Vomiting is a sign of symptom where there is an activation of the vagal response. Fever, of course, is part of the SIRS response. Jaundice will happen if there is edema of the ducts, which will involve the common bile duct, or if there is inflammation of a large portion of the liver bed, in which case the jaundice will be cholestatic in nature. Now, the triad or the Murphy's triad is actually abdominal pain, which is epigastric or right upper quadrant pain, presence of fever, and the presence of leukocytosis. If you have this, then you will have completed the criteria for acute cholecystitis. How do we diagnose this more objectively? So you test again, you look for leukocytosis, elevation in the bilirubin and aminotranslerases may be cholestatic only in nature. It doesn't necessarily mean that there is an obstruction in the bile duct. You get the ultrasound because, again, for patients, these most likely will be with gallstones inside. So you document the thickening of the gallbladder wall by ultrasound, and you document the presence of gallstones inside. The pericholecystic fluid only increases your diagnostic probability, or if you have a markedly or even mildly dilated gallbladder, meaning that the contents cannot pass outside or beyond the cystic duct because the cystic duct is inflamed. Treatment of cholecystitis is surgery, and gold standard is laparoscopic cholecystectomy. Now, these are the other complications related to gallstones and acute cholecystitis, but fortunately, these are less common compared to the simple acute cholecystitis. Common bile duct stones. A majority of common bile duct stones are migrated stones, meaning they are displaced from the gallbladder and they have passed through the cystic duct and now have lodged into the common bile duct. Now, this has to be differentiated from primary bile duct stones. That's why for patients with CBD stones, you have to see if there are gallstones. If there are gallstones, then you are almost 100% sure that this CBD stone is from a migrated gallbladder stone. If there is no gallstone, then you can consider the possibility of a primary bile duct stone, and in which case, especially here in Asia, it most likely be brown pigment stones, and because of a recurrent infection in the bile ducts. There, we usually see the history of abdominal pain followed by jaundice, and sometimes also the pancreatitis is the first symptom of a complication of gallbladder disease. Diagnosis by labs, you may see elevated transaminases. You may also see some abnormalities in the liver function test, such as, of course, elevation in the alkaline phosphatase and the bilirubin panel. And of course, you may see a dilated common bile duct stone in which is defined as CBD of more than 6 millimeters by ultrasound. You may or may not see a stone. If you see the stone, then your diagnosis is established. But if you don't see the stone, but you have gallstones and you have other clinical criteria that may predispose a patient to having gallstones, then you may assume that the dilatation of the bile duct is also because of a CBD stone. You have to remember that the sensitivity of a transabdominal ultrasound falls to about 50% only in the diagnosis of common bile duct stones compared to gallstones, where the sensitivity is about 95%. EUS, CT scan, and MRI are more sensitive tests, but they are more often than not unnecessary as first-line diagnostic tests for choledocholithiasis. Now, we were asking about Charcot's triad in the question earlier. So, Charcot's triad is a triad for non-suppurative acute cholangitis, and the symptoms that form the triad are biliary type pain or biliary colic, jaundice, and fever. Now, this has to be the order of appearance as well. The pain will happen first, followed by jaundice, followed by fever.
Now, the treatment for non-suppurative cholangitis is antibiotics, and then you do your supportive measures like your antipyretics and fluid resuscitation. Then, of course, you still have to refer the patient for decompression of the biliary tree, either by ERCP or surgery or interventional radiology. However, if your Charcot's triad has been compounded by the presence of mental confusion and hypotension, then this is what we call Raynaud's pentad, in which case your patient has a more severe cholangitis because this is suppurative or ascending acute cholangitis, and this is a medical emergency. Antibiotics alone will be ineffective. Of course, you still have to give your antibiotics, but you have to refer the patient for emergency biliary drainage. And for these cases, ERCP is the preferred drainage procedure. But of course, in the absence of expertise or in the if the ERCP has failed, then you may also refer for surgery, especially for patients who still have an intact gallbladder, or in worst case scenario wherein there is no readily available surgeon, you may also refer for a percutaneous drainage just to relieve the pressure inside the biliary system. So the answer to this question is hypotension, because if you have hypotension and the other three choices, then that's already the Raynaud's pentad. We continue with acute pancreatitis. What is the most common cause of acute pancreatitis? Is it alcohol, drugs, gallstones, or is it hypertriglyceridemia? So acute pancreatitis, you may diagnose this if you fulfill two of these three criteria. So you have to have symptoms that is compatible with acute pancreatitis. This is the severe, boring type epigastric pain that radiates to the back. If you have an amylase or lipase elevation that is 3 times the upper limit of normal, of course, if you want to be more specific, you have to remember that while they may elevate in the acute phase of the pancreatitis, amylase will remain to be elevated only in 3 to 7 days. Lipase tends to persist longer. So if the patient has had symptoms compatible with pancreatitis, but it's already more than 7 days before you saw the patient, then there's no use on requesting for amylase anymore. You just have to request for lipase. Now, if you have the third criteria is a radiologic imaging that is compatible with acute pancreatitis. So these imaging can be through CT or MRI or even ultrasound. Now, how does pancreatitis happen? The foregoing theory is still autodigestion. Autodigestion of the pancreas happens if the autoprotective mechanisms of the pancreas are overwhelmed. Now, what are these protective mechanisms? The proteolytic enzymes are packaged in its inactive precursor forms, and that's what we call zymogens. There are protease inhibitors such as PSTI and SPINK1. If you have SPINK1 mutation, then you have familial type of pancreatitis. There is an intracellular calcium homeostasis, and there is an acid-base balance inside. So if you overwhelm all of these autoprotective mechanisms, then autodigestion may occur and acute pancreatitis may ensue. Okay, so what are the most common causes of acute pancreatitis? Gallstones is the most common cause, and this does not only include but is more specific actually for microlithiasis, because the smaller the stone, the higher its tendency to migrate from the gallstone and get lodged into the distal CBD and irritate the outlet of the pancreatic duct. And this irritation, which will cause edema, is what will cause the obstruction that may cause acute pancreatitis. Alcohol is a significant risk factor, especially for males. Hypertriglyceridemia, if the triglyceride levels is over 500. ERCP is also a risk factor for acute pancreatitis, especially for inexperienced endoscopists and repeated cannulation of the pancreatic duct. Certain medications can cause pancreatitis. Blunt abdominal trauma is also a cause of acute pancreatitis. And this is not very common, but abdominal surgery or even non-abdominal surgery can cause the acute pancreatitis. How do we prognosticate or assess the severity of acute pancreatitis? The Atlanta criteria is actually one of the oldest classification of severity of pancreatitis. And this has been modified in 2012. So this is already the modified Atlanta classification. And whenever we talk about Atlanta, we talk about organ failure. So the presence of organ failure will mean a more severe acute pancreatitis. So if the organ failure is only less than 48 hours, or if there is other local systemic systemic complications without persistent organ failure, meaning less than 48 hours, then that is moderately severe. But if there is persistent, meaning the organ failure is more than 48 hours, there is severe acute pancreatitis. So these are several parameters that we use to grade the severity of pancreatitis. The first one is the presence of sears. So if you have all of these parameters, which is the mnemonic is through, which is temperature, heart rate, respiratory rate, and white blood cell count. If you satisfy this, then you have sears. Then you may say that your patient has a more severe pancreatitis. If you have the Apache 2 score of more than 8, or a Ranson score of more than 8 or more than 3, then you have severe pancreatitis. This is what I actually recommend using, BICEP score, because it is one of the simplest tools that we can use to grade the severity of acute pancreatitis. It also has the best prognosticating value in terms of all of these scoring systems. And BICEP stands for Bedside Index for the Severity of Acute Pancreatitis. It also is an acronym for the first letters of each parameter: BUN, impaired mental status; SEERS, age of more than 60 in the presence of pleural effusion; and the cutoff is 3. If you have at least 3 or more, then you have a bad prognosis, meaning you are at risk for more than 15% of mortality. And these are based on the Atlanta criteria. If you have organ failure based on the modified Marshall score, if you are tachycardic or hypotensive, if your PO2 is less than 60, and if your creatinine is more than 2, and depending on the duration, you may say that this is moderately severe or severe acute pancreatitis. And other laboratory parameters such as CRP or MCP1 are also prognosticating values for acute pancreatitis. The Balthazar score is a CT scoring system for the severity of pancreatitis. The Balthazar score is actually dependent on the morphology of the pancreas. So if it's just a normal pancreas, or if there are the presence of fluid collection surrounding the pancreas, then you give each corresponding point depending on the severity of the pancreatitis based on its morphology. If you add now the presence of necrosis, the CT signs of necrosis, then it depends on how much of the pancreas has necrotic tissue, and you also assign points to that. When you add these Balthazar score and this necrosis factors, then you may get the CTSI score, and you also prognosticate the severity based on the score that you get. Now, this CTSI is further modified into modified MCTSI, which will also include the presence of pleural effusion, and the presence of pleural effusion actually is a marker of a more severe disease. The treatment mainstay of acute pancreatitis is fluid management. So you have to be aggressive, but at the same time, you have to be judicious in giving your fluids. You have to monitor your input and your output for these patients. Bowel rest is also recommended, and also analgesic, because your patient is going to be in severe pain. So you also give pain management. Antibiotics are not routinely recommended, but if you will have an indication, such as in the presence of necrotic pancreatitis, then you may give imipenem, because it may penetrate the necrotic tissue. For patients who will be needing nutrition, enteral nutrition is better than TPN, because prolonged fasting is going to promote bacterial translocation and further complications. If your patient has biliary sepsis and pancreatitis at the same time, then you refer those patients for ERCP and sphincterotomy and biliary drainage. So, what is the answer to this question? The answer is gallstone disease. So we continue with the chronic pancreatitis. This image here that you see is an endoscopic ultrasound image of the pancreas with chronic pancreatitis. You're going to see that this is the pancreas here. There are lobulations inside, and there are the distinct intraparenchymal calcifications, which should clue you in to the diagnosis of chronic pancreatitis. So the question now is, what is the most common cause of chronic pancreatitis? Is it alcohol? Is it hypercalcemia, hyperlipidemia, or tobacco smoking? So chronic pancreatitis is an irreversible and progressive destruction of both the exocrine and the endocrine tissues of the pancreas. And as you see here, alcohol is the most common cause of chronic pancreatitis. The most common manifestation of chronic pancreatitis is abdominal pain and weight loss. Of course, here, mild digestion and diabetes refers to the insufficiency in the exocrine and endocrine portions, respectively. But especially for the exocrine function, your chronic pancreatitis should be very severe, such that the remaining pancreatic function is less than 10%, or specifically 7%, for you to manifest with all of these exocrine pancreas deficiency manifestations. So the answer here, we've already said it, it's alcohol. All right, so how do we diagnose chronic pancreatitis? The secretin test is the most sensitive and specific test, and it's going to be positive if more than 60% of the exocrine function of the pancreas has already been lost. Here you can also have decreased serum trypsinogen and decreased fecal elastase. These are the more specific tests, but these are very, very seldomly done here in our setting. What we usually do is get imaging studies. So you can get a CT, transabdominal ultrasound, or endoscopic ultrasound, and you're going to see some criteria. You have to satisfy some criteria for you to diagnose chronic pancreatitis. But in plain films, you're going to see some diffuse calcification in the area of the pancreas, and again, it should make you suspect chronic pancreatitis. If you are going to look at the ductal anatomy using ERCP or MRCP. You're going to see strictures in some cases, and even in more severe cases, you're going to see intrapancreatic ductal stones. So how do we manage chronic pancreatitis? Since abdominal pain is the most common symptom of chronic pancreatitis, so pain relief is one of the most important aspects of treatment. You can also try to give this subcutaneous octreotide, but this is still not available here in the country. Whipple or total pancreatectomy for severe pain because of chronic pancreatitis and because of the risk of development of pancreatic cancer. And of course, you can do something less invasive than surgery by doing a celiac plexus block, where you inject, traditionally, you inject a steroid there to block the pain sensation from the chronic pancreatitis. Later studies are also doing plexus neurolysis using alcohol. For patients with maldigestion or exocrine deficiency, you supplement with pancreatic enzymes and antidiarrheals as needed. Of course, you have a separate line of management for diabetes. Now, in some cases, you may need to do some endoscopic intervention. This is a bit more complicated than bile duct stones and bile duct strictures, but you can also do some stenting procedure and a stone extraction or lithotripsy of the stones inside the pancreatic duct in some patients with chronic pancreatitis. So pancreatic cancer is predominantly ductal adenocarcinoma, and it's 90% ductal adenocarcinoma, meaning it arises from the ducts, and about 90% also can be found in the pancreatic head. And since it's going to be in the pancreatic head, they tend to obstruct the bile flow coming from the common bile duct. So the patients usually will present with jaundice, and when they do present with jaundice, they are most likely inoperable on the time of diagnosis. These are the risk factors. Smoking is an important risk factor for pancreatic cancer, chronic pancreatitis. Diabetes is a risk factor, and also if there is a late onset diabetes, meaning your patient is a non-diabetic and then has suddenly been found to be diabetic at age 60 or 70, then you should suspect that this may be endocrine insufficiency because of pancreatic problems. Cystic neoplasms, specifically the IPMNs, are risk factors in the development of pancreatic cancer. Again, as I said earlier, jaundice is one of the most common clinical presentations. Of course, the other non-constitutional symptoms of malignancy, such as weight loss and anorexia, will be there. Pruritus, if there is a significant and prolonged jaundice. The Courvoisier's gallbladder, which is a palpable gallbladder that is non-tender in a patient with jaundice, should make you really suspect of a periampullary malignancy. Of course, the presence of a Courvoisier's gallbladder presupposes that the gallbladder is normal, otherwise it will not be distensible. There are no available screening tests for pancreatic cancer because all of these tests, such as tumor markers and CT scan, have poor sensitivity. How do we diagnose pancreatic cancer? Imaging is still in the heart of the diagnosis of pancreatic cancer. Cross-sectional imaging, to be precise, but I also highlighted here EUS because EUS is one of the best local regional staging procedure for the upper GI and the pancreas. And ERCP, you may also be able to diagnose pancreatic cancer if you're going to see what we call as double duct sign, where both the common bile duct and the pancreatic duct will be dilated. Serum marker CA19-9, especially in very high levels, should make you suspect pancreatic cancer. Of course, in the appropriate setting where you have a mass and the symptoms that we have mentioned earlier. Treatment, of course, will need to have surgery if its intention is curative. But as I said earlier, only less than 10% of patients will be eligible for surgery at the time of diagnosis. A Whipple's procedure, which is a pancreatic duodenectomy, is the ideal treatment, and which will be followed by traditionally, and this is still what's in your book, a 5-fluorouracil and gemcitabine-based chemotherapy, although this is not what is currently being recommended by the NCCN. A more toxic regimen is being promoted, but again, the prognosis is still poor. Ever since this has been described about 6 decades ago, there has been no significant improvement in the treatment and survival of patients with pancreatic cancer. Palliative therapy in terms of stenting, following an ERCP, and pain management, we've already said this a while ago. So that actually concludes the pancreas part and the gallbladder part of our roadmap, and we proceed now with the last stop, which is the liver. So to begin our discussion, this is the question: what is the best test for hepatocyte injury? Is it ALT? Is it the albumin to globulin ratio? Is it the AST? Or is it GGT? We have to classify these tests as to what it tells us. Okay, the first set of tests will tell us the test for hepatocyte damage. Of course, AST may be found in these tissues: liver, heart, muscle, kidney, brain, and lungs. And ALT is more specific to the liver, such as when you have over 1,000 in your serum, it means that there is extensive hepatocyte injury, and these are the most important differential diagnoses: viral hepatitis, acute viral hepatitis, ischemic hepatitis, and toxic or drug-induced hepatitis. Now, you can also compare the value of the AST to ALT to give you narrower differential diagnosis. If your AST to ALT ratio is at least 2, then it should give you a very important clue that you might be dealing with alcoholic liver disease. In any part or any type of acute liver injury, the ALT, since it's more specific to the liver, should be higher than AST. But if it's about the same degree of elevation, this is what we usually see for NAFLD and for chronic viral hepatitis. The following are tests for cholestasis, or how well the bile is flowing from the source down into the intestines. So bilirubin is here because when we interpret bilirubin, we should look at the direct portion and the indirect portion of the bilirubin. If the total bilirubin is accounted for by less than 15% is accounted for by the direct bilirubin, then we know that the type is indirect hyperbilirubinemia, and these are the differential diagnoses for that type of hyperbilirubinemia. But if you have more than or at least 15% of the total is attributable to direct bilirubin, then these are your differential diagnoses, such as chronic liver disease, Dubin-Johnson syndrome, and Rotor syndrome. Alkaline phosphatase and 5' nucleotidase are actually being produced by the bile canaliculi, such as when there is stasis, there is slowing or stoppage of flow of the bile, you expect that these will elevate in the serum. Now, GGT is actually not a very useful test. except if you want to check for the source of an isolated elevated alkaline phosphatase. All right, so if you have a patient with lymphoma, for example, you may have high alkaline phosphatase because of increased bone turnover. So you get the GGT. If it's also high, then you should rule in an hepatic cause and before anything else. These are what the true liver function tests, because it's going to tell us the biosynthetic function of the liver. Now, albumin is one of the most commonly requested liver function tests. It is synthesized exclusively by the liver. Its half-life is about 2 to 3 weeks. So especially if you're going to use albumin as some sort of acute phase reactant, obviously you should be doing this after 2-3 weeks, because it's not going to give you a good reflection of the current status of the patient because of its half-life. Serum globulin is primarily because will have an increase because of the increase in gamma globulins in chronic liver disease. Now, when we are talking about the reversal of the AG ratio, we're actually not just talking about a low serum albumin, but more importantly, we're talking about the high or the increase in the serum globulin portion. It's actually this increase in the globulin fraction that will reverse the AG ratio. Now, this is a very important and often forgotten concept, because if you have a compensated liver disease, your albumin will still be normal, but you may have cirrhosis. But for the globulin fraction of that patient will always be high. So you look at globulin, because a high globulin in the appropriate setting should give you the diagnosis of chronic liver disease. Coagulation factors, except factor 8, of course. So you request for ProTime, because a ProTime tests for extrinsic factors 2, 7, 9, and 10, and then other vitamin K dependent factors. These are all needed in the coagulation cascade. So if you don't have a good ProTime, then you may think that this patient has chronic liver disease. INR, the serum creatinine, and the total bilirubin are also part of the parameters needed to compute for the MELD score, which is, of course, should give you the synthetic function or a true liver function as well. These are the tests for liver fibrosis. The gold standard actually is a liver biopsy, but we very seldomly request that because it's very invasive. Most of the time we make do with several non-invasive tests, such as transient elastography, or the brand name is FibroScan. We can also request for an MR elastography, and this is a very easily done test. Even in the clinic, we just get the AST to platelet ratio index. If you have a ratio of 0.7 at least, and you already have a 70 to 80% sensitivity for the presence of hepatic fibrosis, while if your APRI score is over 2, then you may say that this patient truly has liver cirrhosis. So what is the best test for hepatocyte injury? We have emphasized on this. The answer is ALT, because it's more specific than AST, while the other ones, albumin, globulin, is part of the biosynthetic function. GGT is test for cholestasis. What is the best test for biliary obstruction? Among these choices, the best answer is alkaline phosphatase. All right, so this is the next question. What is a serologic test for viral replication and Hep B infectivity? Is it surface antigen? Is it IgM anti-HB core? Is it IgG anti-HBC? Or is it HBe antigen? So this is the prelude to the discussion of viral hepatitis, and we begin with acute viral hepatitis. So, acute viral hepatitis, you will have A, B, C, D, and E. And among these 5, only the Hep B is a DNA virus. Everyone else is an RNA virus. And the typical clinical manifestation, if your patient will be symptomatic, is jaundice. And then fulminant hepatitis is one of the rare manifestation of acute viral hepatitis. Is actually happens in less than 1% of the time. All right, so majority of the patients will actually just have a viral prodrome flu-like illness, if at all, which will be followed by jaundice and then a recovery period. Acute hepatitis A is a picornavirus. It is transmitted by a fecal-oral route. It has an incubation period of about 4 weeks, and then of course in a patient with fever, jaundice, abdominal pain, so you may request for an IgM to document that the jaundice is from an acute hepatitis A. That's why you need the IgM portion, and you may document recovery or immunity later on, or if you want to know whether your patient has had acute hepatitis A infection in the past, so you request for IgG or anti-HAV total. All right, this has an excellent prognosis. 99% will recover spontaneously and without any medication. Less than 1% of the time, they may develop fulminant hepatitis, and there is no chronic hepatitis A. Hepatitis B, acute hepatitis B, the incubation period is between 8 and 12 weeks. And then how do we diagnose Hep B? By requesting a combination of viral markers. For acute Hep B, there is also a 95% recovery and 5% chronicity. This tendency to become chronic actually depends on the age of when the patient got the infection, because if you get it during adulthood, your chance of developing chronic Hep B is less than 5%, while if you got it in infancy, then your chance of getting a chronic disease will be over 95%, which this is actually because of the immunity. If you have a mature immunity, such as when you're already an adult, you are going to be able to mount a good response and eliminate the virus. And this is the what is absent among patients who get it during infancy. Okay, so there are 10 genotypes of the Hep B, and here in Asia, ABC, so it's genotype B and C. So this is the typical clinical lab features of acute, all right? So I'm just going to reiterate on the acute part of the hepatitis B. You're going to see here that after some 4 or 8 to 12 weeks after infection, there will be a surge in the expression of the surface antigen, which should go down and become negative at 6 months after exposure. That's why we said that acute is less than 6 months of positivity. And now if you're going to see here that the anti-HBC in turn slowly, and although it's late, it comes later after the HBsAg, but slowly it goes up and it never goes back to zero. Meaning, if you have an anti-HBC positive patient, your patient had an active infection before. Now, if you're going to look here, the anti-HBs here will be negative at around this time. The HBs antigen is going to be negative at around this time, about 6 months time, such as what we call in the window period. So in the window period where both the HBsAg and the anti-HBs will be negative, only the IgG anti-HBC can be seen here. Now here, If you're going to see also that the ALT is high during this phase, but it's going to also normalize as the surface antigen goes down as well. So what is the serologic test for viral replication? It's HBe antigen. If we're going to go back to this graph, we're going to see that the positivity for HBe antigen coincides with the increasing HBsAg concentration as well. And now if you're going to check for the DNA, which is not present in this graph, there's also going to be an increase in the viral DNA at around this point. Acute Hep C, it is also an RNA virus. It has 6 genotypes, and type 1 is still the most common one here in the Philippines and in around Asia. Transmission is parenteral. It has about 7 weeks of incubation, but while there is theoretically an acute Hep C, the acute phase of the infection is almost never seen. How do we diagnose patients with acute Hep C to have active Hep C? They should be positive for both the anti-HCV and the HCV RNA. Next question. Hepatitis D requires co-infection with which viral hepatitis? Is it A, B, C, or E? Alright, so it is an RNA virus as well, but it will require the presence of Hep B for infection. Now, the type of infection, whether this is co-infection or superinfection, you need Hep B for Hep D to be there. Alright, the transmission is similar to Hep B. Parenteral, the incubation is from 2 to 3 months, and the diagnosis is IgM anti-HDV. Now, just a simple cartoon showing the difference between superinfection and co-infection, meaning your patient is previously diagnosed with Hep B and then comes along hepatitis D. So it is infection of Hep D on a patient with already documented Hep B. Now, co-infection means that both the Hep B and the Hep D are entering the patient at the same time. That's why it's co-infection, and the surface antigen of that patient before was negative. Okay, so to answer this question, the answer is hepatitis B. Okay, the last two of the acute hepatitis, acute hepatitis E, or the epidemic or enterically transmitted hepatitis. Genotypes 1 and 2 are virulent, and 3 and 4 are milder. This is also like Hep A, transmitted via fecal-oral route, and this is epidemic, especially in Africa. It takes about 5 to 6 weeks to incubate. The diagnosis is a positive anti-HEV. And for the exam, the importance of Hep E, while we don't see that here in the country, is that it is potentially fatal among pregnant patients. So we now move on to chronic hepatitis. We're almost done. Hepatic inflammation and necrosis that will last for at least 6 months. So you have to diagnose this elevation in transaminase, or for viral hepatitis, the positivity of the markers for at least 6 months before you say that this is chronic hepatitis. The causes are viral hepatitis, medications, and autoimmune hepatitis. And then you have to look for the presence of fibrosis, because it can potentially change the way we manage these chronic hepatitis patients. Okay, so this has already been slightly discussed earlier. If your patient has Hep B, the risk of chronicity depends on when you got the infection, and then also the risk of vertical transmission, because it is one of the most, if not the most common mode of transmission here in the third world country and like the Philippines. If your patient's mother is E antigen positive, there is a very high chance that there will be a vertical transmission of this infection compared to a patient to a mother who is HBe antigen negative. That's why it's controversial right now, but for patients who have been found, pregnant patients who have been found to be diagnosed with Hep B, if the E antigen is positive, then treatment should be discussed for these patients. This is a graph that shows us the typical pattern of chronic. So this time it's chronic hepatitis B. Now you're going to see again the ALT at first will be normal, and then this is the time when the HBs antigen is going up. There's a concomitant increase in the ALT as well. But if you're going to notice, when there is an increase in the inflammatory response, there is a decrease in the actual virologic load inside the body, because your body is mounting an immune response. Now, but the takeaway in this graph is actually these headers. If you're going to see, there's immune tolerance, immune clearance, immune control, and immune escape. Now, the more recent terminology for this is E positive or E negative infection or hepatitis. So obviously, if you are E positive, then you will already be automatically E positive chronic infection if the ALT is normal. However, if the ALT is high and then you're E positive, then this is what we call E positive chronic hepatitis. Of course, the elevation in the ALT means that there's liver inflammation and ergo hepatitis. So this is what is previously called the inactive carrier state. The E antigen is negative, the ALT is negative, and the DNA is negative as well. And in these cases, there might be some fluctuation. The ALT may rise again, and this corresponds to the increase and also in the DNA levels inside the patient. Now, if in the very big bold letters, you're going to see here that we will only try to give treatment for patients with hepatitis or if the ALT is high. So this is true for both HBe antigen and HBe antigen. This is the updated table in the 20th edition of Harrison's. It's going to show you the same thing that we have discussed earlier, but just to emphasize, again, in the ALT that is low, you call that infection here. And then hepatitis is when the ALT is high. But if you're also going to see here that there are several instances that you don't treat even if you have documented a chronic infection. So I created this actually what I called a cheat sheet for you to better and more easily understand what these markers are for, so that hopefully it can make you interpret the results faster. So if your patient is surface antigen positive, then that's already a no-brainer. It is a marker of current infection. But it can also be transiently positive in patients who had a recent vaccination for hepatitis B. Anti-HBs is obviously a marker of immunity. So if you had that, it means that you have immunity against surface hepatitis B. But it doesn't tell you whether your immunity is passive or if it's from vaccine, or active, meaning if you have an active infection before. That's what you look for in the anti-HBC. Now, this will only be positive in a patient who's actually had the infection before. Now, E antigen is the marker of replication and infectivity. The higher the load, the greater the potential to actually infect someone else. And then anti-HBe, of course, is a marker of immune control, meaning it's the virus is all no longer replicating very rapidly. And the conversion from E positive to E negative and then positivity of the anti-HBe is one of the targets in the treatment of hepatitis B. So this is in bold what is the summary on when to start treatment if your patient has persistently elevated ALT, which is defined as at least twice the upper limit of normal over 3 to 6 months, and provided that you have a high DNA depending on whether you are E positive or E negative. This is also what this table is telling you. See here, if this is over 20,000, then yes, you give the treatment to over 20,000, and then over twice the upper limit of normal, you treat. So it follows this recommendation, and this is taken from the 2014 Hepatology Society of the Philippines Consensus on the Management of Chronic Hep B. Now, in certain cases, although this is not for primary physician level, if your patient has advanced fibrosis, even if the ALT is normal, or in a patient who is cirrhotic but with the detectable viral DNA, then you may also start or may need to treat the chronic hepatitis B. These are the available medications here in the Philippines, but you need not bother with this. You just look at these first three, peginterferon, entecavir, and tenofovir. This is what we call the first-line treatment for chronic hepatitis B here in the country. How about hepatitis C? How do we diagnose and screen for hepatitis C? Of course, we will check for anti-HCV. If the anti-HCV is non-reactive, then you don't need to do anything else. The patient does not have HCV. However, if it's reactive, what do we do next? We need to confirm whether this is an active infection or not. We do that by requesting for an HCV RNA. Now, if your patient's HCV RNA is non-detectable, then it means that your patient does not have right now an active HCV infection. It will mean that your patient has had a cured or resolved hepatitis C infection. Now, here you're going to see that this is why we check for anti-HCV, because it should tell us whether this is resolved or cured. But why is it that I said earlier that for you to consider an active Hep C, meaning you have detectable RNA and you tested positive for anti-HCV, that's when you say that you have current HCV, and then this may either be acute or chronic. So why now is anti-HCV a marker of current infection? Well, actually, again, anti-HCV is just going to tell you that the patient has or had active infection with hepatitis C. It's not going to tell you whether this patient has already been cured, because anti-HCV is actually non-neutralizing, meaning even if you have the anti-HCV antibody, it cannot fight off an active HCV infection, as opposed to in hepatitis B, if you already have antibodies against the surface antigen, then you are already considered immune in the development of hepatitis B. So who should we treat? This is much easier than Hep B. Everyone, you recommend treatment for everyone. Patients who have been diagnosed with HCV. Of course, we prioritize some the severe fibrosis or cirrhosis, or those who are co-infected with HCV or hepatitis B, and these high-risk individuals. We are fortunately already in the era of DAAs for Hep C. It began with the development of the protease inhibitors, or the Previrs, the NS5A inhibitors, which are the Asvirs, and then finally we're here in the NS5B inhibitors, the Buvirs. Now, this is a summary that I made. This outlines actually some of the Hep C medications that you may give, but I highlighted it here because these are what is only available here in the country. So basically, if you don't want to memorize anything, you just notice that all of these three regimens contain sofosbuvir. These are all sofosbuvir based. More or less 12 weeks is the treatment of duration for hepatitis C, and then you add ribavirin if your patient has cirrhosis, more or less. So if you don't want to bother with the details of this table, then that's all you need to remember right now, and it's going to make you understand the other parameters. Okay, so we are done with viral hepatitis. We are now in drug-induced liver injury. We are nearing the end of our discussion. It depends on the type of the medication, and it produces DILI by several mechanisms. So if it's acetaminophen or paracetamol here in the country, carbon tetrachloride, then the mechanism is by direct liver toxicity. Isoniazid, anesthesia, which is halothane, chlorpromazine, and all these other medications, amiodarone, produces idiosyncratic DILI, and then cholestatic DILI are from contraceptive use, steroids, and erythromycin. Alcoholic liver disease the pathology is almost exactly the same as non-alcoholic fatty liver disease. The only difference is the presence of a significant amount of alcoholic intake. Now, the alcohol you need to get from the history, the quantity, and the duration. This is the traditional definition of a significant intake of alcohol: 60 to 80 grams for men, 20 to 40 grams for women. But this is the more updated definition: 14 drinks per week, cumulative drinks per week, and then 7 drinks per week for women over the last 10 years. Now, what is one drink? One drink is approximately one beer or one half a glass of wine or a shot glass of the spirits, and this is roughly equivalent to 12 grams of alcohol. Now, it is important because Hep C and alcohol does not mix very well. It is a very potent factor in the development of hepatocellular carcinoma. Now, alcoholic liver disease, the important part here that may be asked in the boards is the prognosis. If your Madre discriminant function, or the MDF, is at least 32, or if the MELD score is at least 21, because this is when you're going to give treatment. Treatment obviously involves abstinence, absolute abstinence of alcohol, and then if you have alcoholic hepatitis, if you fulfill this criteria, then you give prednisolone. I would like to emphasize that since the 19th edition, this has already been revised. In the 19th edition of Harrison's, pentoxifylline is still there as a potential treatment for alcoholic hepatitis, but now in the 20th edition, it's no longer there in the pathway. You only give prednisolone or prednisone for 4 weeks. NAFLD, again, the pathology is almost the same as in alcoholic fatty liver disease. It is currently the most common chronic liver disease, even here in the country. There is an increased liver fat because of the changes brought about by the multiple hit hypothesis. It's no longer the 2-hit hypothesis, and it is strongly associated with the metabolic syndrome. In fact, it is considered as the liver manifestation of metabolic syndrome. And the components of the metabolic syndrome, I have mnemonic, IDHO, insulin resistance, dyslipidemia, hypertension, and obesity. There is a mild elevation, usually between 2 to 3 times the upper limit of normal in the transaminases. There is an increased echogenicity by ultrasonography, and liver biopsy, again, is the gold standard, but most of the time is unnecessary. The treatment for NAFLD is still not yet invented, but it has been proven that for patients with steatosis, if you lose 5% of your weight loss, then you may improve steatosis. If you have steatohepatitis, meaning you have elevation in the SGPT and SGOT, then you need to lose at least 10%, 7 to 10% of your body weight to improve the steatohepatitis. But if you must give something for the patient, then this has modest benefits, vitamin E, and pioglitazone. Vitamin E, there should be a caution. It should not be more than 800 milligrams IU per day because it increases cardiovascular morbidity. And then also it is a risk factor for the development of prostate malignancy. Pioglitazone, as with any thiazolidinedione, this is a contraindication for patients with congestive heart failure. Liver cirrhosis, these are all of the etiology. Alcohol and hepatitis B are the most important etiologic factors of cirrhosis here in the country, and the NAFLD is slowly and steadily rising as to become the one of the most common causes as well. How do we diagnose these patients? By doing liver function tests and proving that there's an impaired liver function test. There will be some signs and symptoms of cirrhosis. Biopsy is the gold standard but seldomly necessary, and other imaging tests. But for you to have a conclusive or at least very suggestive imaging result that will tell you it's cirrhosis if you have anatrophic liver on imaging. These are the stigmata of chronic liver disease. This is not specific for any etiologic factor. If you have chronic liver disease, you may present with one or multiple stigmata as shown here on this slide. So what stigmata is indicative of the presence of portal hypertension? Is it spider angioma, gynecomastia? Is it jaundice, or is it splenomegaly? Well, obviously, the answer is splenomegaly, because portal hypertension, meaning there's an increased pressure in the portal vein, and you know that the superior mesenteric vein and the splenic vein are what drains and joins to become the portal vein. So the spleen, if there's an increased pressure also in the splenic vein, then there will be splenomegaly. Portal hypertension occurs when the hepatic venous pressure gradient is at least how much millimeter mercury? Is it 4, 5, 6, or 7? So we discussed the complications of cirrhosis, the most common of which is ascites. Ascites is the most common of the three major complications of cirrhosis, and the development of ascites in the setting of cirrhosis is a landmark in the natural history of chronic liver disease, because this predisposes the patient to refractory ascites, secondary bacterial spontaneous bacterial peritonitis, hepatorenal syndrome, and hyponatremia. Portal hypertension will bring about variceal hemorrhage and hepatopulmonary syndrome. Now, what is hepatopulmonary syndrome? Hepatopulmonary syndrome is the presence of liver disease. It's a triad of a liver disease, intrapulmonary vascular dilatation, and arterial hypoxemia. And then one of the last major complication is hepatic encephalopathy. So portal hypertension is defined as the elevated hepatic venous pressure gradient of more than 5 millimeters. Okay, so you compute for the HVPG by subtracting the free hepatic venous pressure from the wedge hepatic venous pressure. And then if it's more than 5, then you have portal hypertension. If there is more than 10 millimeter mercury gradient, you will expect formation of varices. And if it's more than 12, then those varices are already at risk for variceal bleeding. There are two hemodynamic processes involved in the development of portal hypertension. The first one is increased resistance, intrahepatic resistance of blood flow because of the fibrosis, and increased nitric oxide mediated splanchnic blood flow, because nitric oxide will cause vasodilatation of the splanchnic vessels. So the answer to this question, this is a trick question. So since the definition is more than 5, so the answer should be 6. All right, variceal hemorrhage. There are several factors that will predict the risk of bleeding. Of course, the more severe the cirrhosis, the more likely that the patient will bleed. There's an increased gradient, the hepatovenous portal gradient, if there are large varices, and then if there are endoscopic stigmata of imminent bleeding, such as the red whale sign, hematocystic spots, and the white nipple spots. Treatment for variceal hemorrhage, we have discussed this during the upper GI bleeding part. You ligate them by rubber bands, and then you give vasoactive substances such as somatostatin and octreotide. You may give primary prophylaxis in the form of non-selective beta blockade and variceal ligation for very large varices. And then secondary prophylaxis is rubber band ligation followed by usage of non-selective beta blockade. This is the Child-Pugh score. Okay, so there are 5 parameters. This is bilirubin, albumin, prothrombin time, ascites, and encephalopathy. Now you give corresponding points depending on the values or the presence or severity of these findings. You don't need to memorize this, but if you're going to memorize the Child-Pugh score, you just memorize this, the one in the middle, because if it falls into that category, then you give 2 points. Anything better than that, then you give 1 point. Anything worse, you give 3 points. Now, Child-Pugh is given over 3 classes, A, B, C, depending on the cumulative number of points. But of course, even in the same child class, the numbers matter, meaning 15 is the very worst case, and those with a score of 10 fares better than those with the score of 15. It tells us a survival of these patients with cirrhosis. Ascites. When we examine patients with ascites, the most important test is cell count and differential count. The book says that if you only have 1 drop of ascites, this is what you request for, a cell count and a diff count. You will probably get an idea on where the ascites is coming from by computing for the serum ascites to albumin gradient. You compute it by subtracting the ascitic fluid albumin from the serum albumin. If the gradient is more than 1.1, then you are almost sure that the cause of the ascites is because of portal hypertension. If it's less than 1.1, then there is definitely no portal hypertension. And this may be attributed to peritoneal diseases such as carcinomatosis and TB peritonitis. Spontaneous bacterial peritonitis is a very common complication of patients with refractory ascites. It is defined as the presence of an absolute ascitic fluid neutrophil count of over 250. What is the treatment for ascites? Sodium restriction, and then giving of diuretics in a specified ratio. Furosemide at 40 milligrams and then spironolactone at 100 milligrams. And when you adjust using that ratio as well. Large volume paracentesis, especially for patients with very large ascites and with refractory ascites. Hepatic encephalopathy is a very bad complication of cirrhosis. It is defined as alteration in mental status and cognitive function. It is graded according to the West Haven criteria, grade 1 being the mildest and grade 4 being the worst. Grade 1, there's going to be manifestation alteration in the sleep-wake cycle, and then 2 will be the presence of asterixis. 3 would be some either very irritable or very violent patients, and then 4 would be stupor or hepatic coma. This is derived because of the presence of too much of these neurotoxins such as ammonia and mercaptans, which serves as false neurotransmitters. And you have to identify as much as possible in a patient with hepatic encephalopathy. You have to identify these if there's a presence of any of these precipitating factors, because the number one treatment is to address that precipitating event. Such, for example, if you have GI bleeding, you have to control the bleeding. If your patient has electrolyte imbalance, you need to correct them. And then you give antibiotics for infection. If you remember earlier when we said you give antibiotics for cirrhotic patients with GI bleeding, because they can precipitate the development of hepatic encephalopathy. Okay, so you give lactulose, and which is a non-absorbable disaccharide, and antibiotics such as neomycin, metronidazole, and what is currently one of the best here in the country is rifaximin. The last complication of cirrhosis, and the worst one, is hepatocellular carcinoma. In the book, it's because of aflatoxin B1, but you don't really see that here in the country. It's really more related to hepatitis B and C, and cirrhosis, especially if there's alcohol involved. And then the staging is not the TNM that we know. It has a separate or different, actually, staging systems. The Okuda, CLIP, and BCLC are just three of the many, and it takes into account the size and the number of the tumor. And this ascites, albumin, and bilirubin are actually just part of the Child-Pugh score. So you take all of these parameters. These are common to all three of these staging nomenclatures. But AFP is part of CLIP, and then the performance status is part of the Barcelona clinics. Okay, so how do we diagnose hepatocellular carcinoma? The tumor markers play a role here. AFP is still an important tumor marker for HCC, but the more specific one would be the AFP-L3, especially in patients with fibrolamellar type hepatocellular carcinoma, although that's very rare, wherein the AFP will be normal, but the AFP-L3 will be high. And then also des-gamma carboxyprothrombin, or DCP, or PIVKA2. This is also a tumor marker, and high levels of all three should give you the diagnosis of HCC. And all of these are now available in the country. Previously, only AFP is available. Ultrasound is the preliminary imaging of choice for HCC, in which you're going to see a liver mass and a cirrhotic liver. After you see that, I hope you request for a triphasic CT, for which you're going to see the very typical or classic finding of early arterial enhancement with delayed or portal venous washout. So if you have this, and then you can say that you have diagnosed HCC even in the absence of biopsy, because actually HCC is a malignancy wherein you can give a definite diagnosis even without a biopsy. MRI with gadolinium studies is also one of the dynamic tests that you can do for hepatocellular carcinoma. Now, as with any malignancy, the treatment depends on the stage. Surgery is recommended for very early stages or very small tumors. Local ablation you can also give in the form of radiofrequency ablation or microwave ablation. TACE or transhepatic artery chemoembolization, and then tyrosine kinase inhibitors in the form of sorafenib and lenvatinib. Again, you will give this depending on the stage, and this is what we do actually here in the country, and it's what's in your Harrison's, the Barcelona Clinic's liver cancer classification. So you have to stage the patient depending on the liver function and the performance status, and then the number of the tumors and the size. So for very early stages, you can still provide a curative treatment wherein you can ablate or you can resect or even do transplantation. But for intermediate stages, cure is no longer part of the options. You give palliative treatment in the form of TACE here or systemic therapy using what we have said earlier, sorafenib or lenvatinib. And for terminally ill patients, you just give best supportive care. So this has been the end. This is the end of the road, rather, for our GI review. We have discussed the luminal side, the gallbladder, the pancreas, and the liver. So I hope you have learned a few things here, and I wish you the best of luck, and I will see you when you have crossed the finish line.